All attendees are in listen-only mode.
Hello, and welcome to Center for Change's webinar. My name is Carrie Jacobson. I am outreach for Center for Change. Tamara Noyes is unable to be with us today, so I'm the fill-in today. Just wanted to give a little bit of information about Center for Change. Center for Change is in Orem, Utah. We have inpatient medical stabilization, we have residential, we have PHP, IOP, and outpatient. We work with adolescents and adults with primary eating disorder concerns. We have locations in Orem, in Salt Lake City, Utah, and also in Boise, Idaho. I wanted to thank everybody for joining us today. It's a beautiful day here in Salt Lake, and just wanted to give a little bit of information before we get started with Dr. Robison. Attendees are welcome to submit questions in the question pane located in the toolbar, and the presenter will try and get to a few questions at the end of the presentation. A copy of the post-test is also in the handouts pane in the toolbar. Feel free to view or print the test questions for review during the webinar. However, the test must be taken online to receive CE credit. A copy of the PowerPoint slides and other handouts are in the handouts pane in the toolbar. At the end of the presentation, the webinar program will ask attendees to complete an evaluation. This gives us great feedback for future webinars. After about an hour, when the presentation ends, attendees will receive a follow-up email with instructions regarding the post-test and how to receive their certificate of attendance. Sometimes that information does go into like a junk or a spam email box, so please check that. And then, so let's get started. Let's give Dr. Robison as much time as possible. Dr. Robison is Center for Change's medical director, and I will let him kind of give a little bit more information about his background and then get him started. So I will turn over the presentation to you, Dr. Robison. And then I'll turn off my camera and mute myself, but I'll still be here if you need anything.
Thank you. All right, I think we're all set. It's good to be here with you. And I'm always excited to talk about psychedelics and eating disorders, two topics near and dear to my heart. I've been the medical director at Center for Change since 2017, and I'm also Chief Medical Officer at an organization called Novamind. And I'll give some more intro in a moment, but first I wanted to share a quote from a participant in an MDMA-assisted psychotherapy study conducted by MAPS, a nonprofit, because this is what it's all about. It's about, can we push the needle in our efforts to help alleviate suffering? So one of the participants said, "I'm tempted to say MDMA gave me hope. But that word isn't right. The insight was more substantive than hope. I'd held the sensation in my body. I understood at a visceral level what might someday be mine, the sense of peace and joy within my body. From there, the therapeutic process could unfurl. For me, the therapeutic process could unfurl from there." So here's what we're going to talk about. Some of the challenges in eating disorder treatment that I'll touch on briefly. What this psychedelic renaissance is all about that we hear in the news, that we see popping up in more and more healthcare settings. We'll talk about ketamine specifically as both a rapid antidepressant and also a psychedelic medicine with other therapeutic benefits. We'll talk about MDMA, a little bit on psilocybin and ayahuasca. And so a little background. Again, my name's Reid. I'm a psychiatrist, and my background is in clinical trials. First and foremost, I started my career at the University of Utah on faculty doing clinical trials, and I did a fair number of clinical trials. I've done 200 of them by now, but after a dozen or two, there was one that stood out to me and changed my path. I was approached by back in 2011 by Johnson & Johnson to lead the Utah site for their IV ketamine study. And I've got to admit, I was getting discouraged by the psychiatric medicines available to us and coming down the pipeline. But then through the course of sitting with dozens of individuals through their ketamine journeys who had treatment-resistant depression, I was blown away. Not only was this non-daily medicine effective, it was effective quickly, and without taking a daily medicine, there were even some lasting changes. So I started working with ketamine more and more, got a grant from Intermountain to study it back then in 2011, and have sat with thousands of people since. I have more recently developed a couple specific ketamine-assisted psychotherapy protocols, including one with Dr. Adele LaFrance, who many of you may know as she was a keynote speaker for our Center for Change conference a couple years ago and developed a therapy modality called emotion-focused family therapy that's widely used in eating disorders, including here at the center. And I'm working with other psychedelic medicines as well. And I've been the coordinating investigator for MAPS and their MDMA-assisted psychotherapy study of eating disorders that we've been working on for a year or two, but is through the FDA, the IRB, Health Canada, and will be launching pretty soon for anorexia and binge eating disorder. Working with other psychedelic medicines as well, like ayahuasca in therapeutic retreat settings in jurisdictions where I can. It's not accessible outside of research here, but it is in other parts of the world. And so let's, I'm going to play a little video just that gives an overview of what I've been working on at Novamind, including some client testimonials that I found touching. Okay.
So this is the first treatment that's ever given me any relief from suicidal ideations. It's like they're gone.
The way I describe it to people, my friends and family, it's been like my brain was like a desert, and now it's like a flourishing forest or a jungle or something where it's filled with life and connections and growth.
It's been a 180. I went from not wanting to leave my bed to wanting to actually go out and do things, see my friends. I'm excited.
We're in the middle of a psychedelic renaissance where there's a resurgence of psychedelic science and clinical studies. We're building clinics, retreats, research sites to help bring psychedelic medicine into everyday healthcare.
So this is the first treatment that's ever given me any relief.
There we go. I think I figured out how to advance the slide. And here's a little more kind of a bird's eye view of what we're up to with clinics in Utah and also retreats in these alternate jurisdictions where these medicines are accessible to really provide access to above board evidence-based psychedelic assisted psychotherapies for individuals who need it most from within the current mental health system, like using someone's health insurance whenever possible and providing these integrated with traditional care, like diagnostic services, medication management, and therapy. And so on to some of the challenges that I'm sure most of you are well aware of that exist in eating disorder treatment. There are no FDA-approved medication options for anorexia, for example. For bulimia, there's one dating back quite a while ago, Prozac, approved to reduce binge purge cycles in bulimia. But obviously there is a strong need for more options in all of the eating disorders. In binge eating disorder, we have Vyvanse approved to reduce the number of binge episodes per week. But it's also not a fit for everyone and leaves some more work to do, even though all of these treatments have their role. But in eating disorders, we need a sense of urgency. We need proactivity from screening through diagnosis to treatment, because often we don't act quickly enough. You know, if you compare our field to other specialties, like you may come in to receive, and this is a systemic issue, you may come in to receive some initial treatment for eating disorder care, get a diagnosis, but sometimes the treatments are not accessible or approved by insurance companies early enough, but we'd never do that in something like cancer. We wouldn't say, come back when it's more advanced. We would get on it as early and proactively as possible. And so that's one thing I would point out is don't wait until the full workup is done, the diagnosis is clear. Let's jump on it. We all have work to do with our relationship with food and body. And you know, even if something doesn't develop into a full-blown eating disorder, the disordered eating and behavior patterns and body image distress in and of itself can be quite distressing. And sometimes we do need to venture out into the unknown in search of new options for our clients. And that's what led me down this path of exploring psychedelic-assisted psychotherapies. And so there is this resurgence of research in recent years after a long, dark period where these medicines were just not accessible because of you know, some political factors and some fear around them a few decades ago. But now they're reemerging as new treatment paradigms and showing great promise, including and especially for some of the most difficult to treat mental health conditions. So there is this renaissance going on, and I would call it more of a mental health revolution. Alongside this, we have psychedelic medicines coming back into research labs and clinics and fast-tracked from the FDA on drug development paths. But we also have more attention and paid to our mental health and wellness, and we're seeing some reductions in stigma. This is alongside some increased needs that have come along with the COVID pandemic, and there's just this era we live in. So while there's suffering, there's also hope. And a note on psychedelic medicines in general, and I'm going to fly through these slides. I provided more than we'll have time for, so you can flip through them at your leisure. But bear with me as we cover a lot of ground. So a lot of research has been conducted. Data continues to come out as a whole that these medicines are not only safe but well tolerated, and in many cases extremely effective for people. And though more research is needed to understand safety and the way of delivering these favorable safety profiles and the strong efficacy really suggest the need for deeper exploration of these things. If you plot psychedelic medicines on a chart against all sorts of substances, even legal ones like alcohol, they consistently come out with a more favorable safety profile across all parameters. Not for everyone, but extremely safe and tragically what you might call overscheduled or over-controlled historically, that's made it difficult for this research to progress until now. And so to give you an example, this is some more data from phase 3 studies of MDMA conducted by MAPS for PTSD. The FDA granted breakthrough therapy status, and this treatment modality is progressing towards becoming, hopefully, and a prescribable treatment option within the next 2-3 years. So this is from phase 2 data that I just found mind-blowing. Individuals with severe PTSD going into 2 to 3 doses of MDMA plus therapy, approximately 70% came out of that no longer meeting criteria for PTSD. 6 months later, 12 months later, still not meeting diagnostic criteria. And this is with a medicine that's not even a daily pill. And in the psilocybin data being studied mostly right now for severe depression, also for end-of-life anxiety, cancer-related anxiety and depression. There are also a number of studies going on using psilocybin for eating disorders like anorexia. There's one that I'll talk about later happening at Johns Hopkins, one at UCSD, one at Imperial College in London. But this chart shows a study by Robin Carhart-Harris and colleagues at Imperial in the UK, published in the Lancet Psychiatry, and they found that 2 doses of psilocybin plus therapy led to rapid improvements in mood, but these were sustained. And again, 2 doses of a medicine plus psychotherapy with this kind of results, to me, is incredibly exciting. And you may have noticed in the news and in some more and more documentaries that are coming out about this kind of thing that participants in psilocybin studies very often rank that experience as one of the most meaningful in their lives. A very significant mystical or even spiritual experience that sticks with them. And so there was a book that came out in the past few years that you may be familiar with, you may have even read. It's a bestseller by Michael Pollan called How to Change Your Mind. And I'll just read one quote from that book. I'd encourage you to check it out if you haven't, because it has really helped open up the dialogue about these. Michael Pollan said, "Was it possible that a single psychedelic experience, something that turned on nothing more than the ingestion of a pill or square blotter of paper, could put a big dent in such a worldview, shift how one thought about mortality, actually change one's mind in enduring ways? The idea took hold of me. It was a little like being shown a door in a familiar room, the room of your own mind, that you had somehow never noticed before, and being told by people you trusted, scientists, that a whole other way of thinking, of being, lay waiting on the other side. All you had to do was turn the knob and enter. Who wouldn't be curious? I might not have been looking to change my life, but the idea of learning something new about it and of shining a fresh light on this old world began to occupy my thoughts. Maybe there was something missing from my life, something I just hadn't named." And so he went on this exploration. First, he was just going to write about these things, but then he ended up experiencing them. And I'll read a little bit more. He said, "The journeys," talking about his own experience, "have shown me what the Buddhists try to tell us, but I've never really understood, that there's much more to consciousness than the ego, as we would see if we would just shut up. And that its dissolution or transcendence is nothing to fear. In fact, it's a prerequisite for making any spiritual progress. But the ego, the inner critic who insists on running the mental show, is wily and doesn't relinquish its power without a struggle. Deeming itself indispensable, it will battle against its diminishment, whether in advance or in the middle of the journey." I'll leave it there for now so we can move on. But how might psychedelics help with eating disorders? Classic psychedelics like psilocybin, LSD, ayahuasca are thought to interrupt what's called the default mode network, which you could consider the neurobiological seat of the ego. It's a collection of pathways that govern our self-image, our autobiographical memories, our deeply ingrained beliefs and thought patterns. And while there are many mechanisms of psychedelics that you can see from brain imaging studies and other research approaches, findings seem to converge on this theme of toning down the ego, the default mode network. And this, very interestingly, is what seems to be overactive in eating disorders, where there's ruminating, thinking, worrying about caloric intake, food rules, where there might be some behavior patterns like compulsive exercise, other eating disorder behaviors, body checking, etc. So I'll get into that with an analogy a little more. So psychedelics, you could think of like a fresh coat of powder and provide this break from the everyday patterns, because our mind, through its repetitive thought patterns and and our behaviors can get stuck in ruts, kind of like grooves on a ski slope from traveling those same paths over and over. But then psychedelics come along like a fresh coat of powder and lets you consciously choose the course down the mountain and choose the next set of tracks. And then if you repeat those efforts, they can become the new habits, the new automatic and default behavior, because we are, you know, habitual beings. And, you know, it used to be, and maybe some people still consider it taboo to talk about personal experiences, but I disagree. When I'm working in these ways above board with psychedelic medicines, I can tell you that when I first went out to seek, say, ayahuasca in a therapeutic retreat setting so I could experience it, first of all, to know how to work with it and bring it to clients, this was striking to me. The reboot of the brain, the blank slate, the fresh start, where coming out of that kind of setting brought with it a new clarity, a new vigor, a new energy level, but also the ability to just consciously navigate decisions that might have previously been maladaptive ruts. It was really quite striking. And so looking at how these things work compared to, we talked about Prozac as the only FDA-approved medicine for bulimia. Prozac and SSRIs work through serotonin receptors, but the result is some decreased responsiveness in the limbic system or the emotional center of the brain. You could even call it emotional blunting. But psychedelics also work on serotonin receptors. Classic psychedelics hit a receptor called 5-HT2A, causing a surge of serotonin release. But the result is more of enhanced sensitivity, more processing of stuck emotional states. And when you combine this with therapy, it can be quite powerful. Another summary of this is psychedelics hit that 5-HT2A receptor, blast a serotonin, creates these short-term results of a psychedelic experience, but the longer-term effects can be loosening of the mind or relaxing some of those tightly held beliefs. And so there was a paper also by Robin Carhart-Harris and colleagues in the UK that brought this together in a really nice way. They called the resulting framework Rebus, or relaxed beliefs under psychedelics. And I point this out, bear with me, because I think it has relevance to eating disorders. So the main takeaway here, and you can look back at these slides on your own if you'd like, the main takeaway is that psychedelics work to relax prior beliefs. And this relaxes them from the top down. This allows, like our thinking mind can relax the hold that has and allow bottom-up information like our body experience, our embodied presence in the world, to take more of a driver's seat, allowing us to listen intuitively to what our body needs rather than listening to the noisy egoic mind. So in other words, you cling less to old beliefs and patterns, and you're more open to new ideas, experience. So if you always hated going to somewhere because of a bad experience, like going swimming at a public swimming pool, let's say, you might be more open to try it out now after relaxing those prior tightly held beliefs. And so this has implications across a number of mental health conditions, from eating disorders to OCD, depression, trauma. And I will move on to talking about ketamine for a little bit. Ketamine's been around a little while. It was developed decades ago and has been FDA approved as an anesthetic for quite some time. It's on the World Health Organization of essential medicines list, carried by backpack medics in war zones, given millions of times in procedures, procedural sedation, ERs, ambulances. So it's well known to us as a medicine, but what was interesting is over the past few decades, its antidepressant properties have become very interesting and studied more and more, especially since 2000, where there were a couple of pivotal studies, small but powerful ones, that showed ketamine's rapid antidepressant action. And then fast forward until 2019, we have an FDA-approved nasal spray with S-ketamine in it, one of the two what's called enantiomers of ketamine. So like a cleaned up half of ketamine in nasal spray, brought to market by Janssen for treatment-resistant depression. And then last year, they also added suicidality as an indication. And so ketamine is used not just in anesthesia, but in medicine. We can prescribe approved meds for other purposes besides what it was approved for. This is at the clinician's discretion and is up to their judgment based on safety considerations and evidence-based decision-making. And so we're able to use ketamine legally off-label for all sorts of conditions. It's been used for chronic pain for quite some time, depression more and more over the past 15 years. And now with Spravato being FDA approved, we have an FDA approved option, which means that it just lends more kind of credibility and safety to it and gets insurance companies on board. And this is from the director of the National Institute of Mental Health, who said a while back, recent data suggests that ketamine given intravenously might be the most important breakthrough in antidepressant treatment in decades. So let's talk about what the heck is going on here with ketamine. Why would Dr. Insel say that about a medicine when he's researched a lot of medicines? So I've broken it down into 4 main mechanisms because ketamine, like most medicines, is complex and it has multiple mechanisms. But I'll provide an analogy as well to illustrate what I'm trying to show about how it works. Is ketamine is often talked about as an NMDA receptor antagonist, leading to a surge of glutamate. So it's a glutamatergic medicine, a surge of glutamate release that can lead to rapid improvements in mood. There are papers in prestigious psychiatry journals talking about this glutamatergic hypothesis in depression and other conditions. And so this is kind of like waking up dormant neurons, like you're jump-starting a car battery, let's say. Because we'll see that, actually, I'll go forward to it and then I'll come back. Brain activity is reduced in certain areas in depressive states. And so ketamine, a single dose of ketamine can jumpstart that in the majority of individuals. And so the next mechanism I'll talk about is a little part of the brain we don't hear about much, called the lateral habenula. It gets overactive in stressed out states and depression in times of stress into this thing called lateral habenular burst mode. And the habenula is like the anti-reward center, not a good feeling to have this overactive, stressed out state. But giving a dose of ketamine is like putting a fire extinguisher on that, or providing immediately, although temporarily, turning off that burst mode so the individual can feel a little lighter and do some more therapeutic work on their healing journey. We hear about neuroplasticity a lot with psychedelics, their ability to provide that fresh coat of powder, let's say. And the same is true for ketamine. There's also research supporting it with Spravato, as we would predict. But ketamine works in another way through this pathway called BDNF, brain-derived neurotrophic factor, leading to new nerve growth and fostering new connections. So it creates this window of neuroplasticity where, especially if we get in there and do some productive therapy, it can make those insights and connections and new behaviors and habits stick, kind of like miracle grow for neurons. And then lastly, ketamine is like a reboot, interrupts the connection between the cortex and limbic system, at least briefly. So it's a timeout from that ego-based spinning mind, worrying about something we just said or did, worrying about what's coming up, or overthinking. Mind you, you do need a little bit of ego to navigate the world, right? We need to be able to remember that we have a 3 o'clock appointment, or we need to pick our kids up at such and such a time. And so we don't bump into each other essentially, but our egos can get out of control due to this worrying. It can kind of, there's a snowball effect. So in recent years, I started working with ketamine as a medicine, and it does have powerful properties as just a medicine in both depression, pain, and other uses. But when paired with therapy, I strongly believe the effects are more pronounced and more long-lasting. And so this is a summary of how it works in therapy. We'll give ketamine in clinic in a couple different ways. Most people start with receiving it by a shot, an intramuscular injection in the shoulder, putting on eye shades, headphones, a playlist carefully chosen in collaboration with the clinician, the client, and then in a supportive environment, in a recliner, relaxes into a journey, a dreamlike state. And ketamine, through these mechanisms, it helps us, it's fear reducing, heart opening, and can help you revisit past memories that were too difficult. Reduce that fight or flight mode, see your life from a new perspective. So it's similar to the classic psychedelics in that it does provide this timeout and this new perspective and this neuroplasticity window. And there's this concept of inner healing intelligence that really, it's been around a while, but emphasized by the MAPS MDMA therapist training, that the therapist is there to help the individual heal themselves, to help them figure out their path and make positive strides towards the direction they want their life to go, towards their true self, rather than telling the individual what to do or trying to fix them. Because we do all have this innate ability inside ourselves to heal. Like if you cut or scrape yourself, the body takes care of it. And I believe the same goes for our minds, our hearts, our souls. And so at low doses, ketamine can open up this state of more free thinking, creative problem solving, openness to new insights, less stuck in old habitual thought patterns. And so the other way we use ketamine is in low doses, sometimes before a therapy session. And let's see. Components of a typical course of ketamine-assisted psychotherapy would ideally involve a preparation session to not only make sure someone's a candidate for this type of therapy, but also to establish that relationship of trust with the treatment team, to start to work on the set and setting that are so important in psychedelic medicine therapy courses. Because psychedelics are, you could think of as amplifiers of what's going on in the psyche. And if you're going in with a lot of fear, anxiety, or apprehension about things that we could otherwise control, like the environment, is someone going to walk in? Who are these people helping me? That can be amplified. But if we can take care of that safe container, then that really facilitates the work. And then a typical course of ketamine therapy, while it's individual, it might be once or twice a week for a few weeks with therapy in between, individual, maybe group therapy. And then these sessions are ideally pretty soon after, within a few days after the ketamine dosing sessions, to take advantage of that window of neuroplasticity. And so with the work that's been forging ahead over the past decade or more, understanding more and more how these medicines work and the value of therapy, we're now able to move towards an understanding of how to give them, what works best for whom, for what conditions, in what context. And this is an example of a course of ketamine-assisted psychotherapy that we conducted, that I led along with Adele LaFrance here in our clinics in Utah last year, where a family flew out, the adult daughter with an eating disorder that was severe. Parents came as well, and we did a lot of therapy individually and together, and everyone went through the course of ketamine-assisted psychotherapy together. And such a powerful, touching, and healing process to participate in and watch unfold. And I should point out, just as a disclaimer, that we don't give ketamine unless there's a diagnosis of record, unless we've done the right screening. But I also know, practically speaking, that we all have suffering. We all need help sometimes, and especially when working with a loved one through, serious illness of any kind, that can take a toll. And there's power that I'll talk about more in this presentation. Power, healing power in the family unit and in our groups and societies. So back in 2018, 2019, we did a pilot of group-based ketamine therapy on the RTC unit at Center for Change. And that was such a neat process to be a part of as well, because we were able to go in with groups of 4 every Monday morning. We'd go, we'd prepare for it, talk about it, set intentions, and then go into this group setting with nursing and a medical psychiatric support, and that safe feeling of a container, the trusted team and set and setting, and then come out and discuss that together, discuss it individually with treatment team members. And I remember some specific experiences that will stick with me forever that individuals had, of even for a moment in time, having a sense of self-love, having this ability to let go of the body image struggle and see oneself clearly for a moment, because it opens up a path of what's possible, of where to go. And there is power in the groups, power in seeing that we're not alone in this, in learning from each other in parallel. And so here's one example of, as we tracked scores of depression and anxiety, if you look at dose 1 of ketamine, depression scores, anxiety scores for this individual were quite high in the severe range. A little bit of reduction after the first one, a little more reduction after the third, and then down into, for anxiety, down into a normal range by week 4, and mild range for depression. So this is from one of the participants there, who so graciously gave some feedback about their experience. Trying ketamine allowed me to see the possibility of a life I could have. While the effects did not last, my very first experience snapped me out of a state of lifelong deep disconnection that I didn't even know I'd been experiencing. Suddenly, I was able to live in the world in the way people had always described it. Though I'm still trying to figure out how to attain that level of connection after catching a glimpse, that one experience was so essential. I could finally feel hunger and fullness cues. I felt what it's like to live in a body instead of living at a short distance from it. I felt connected to others and genuinely cared about their well-being. I felt human for the first time in a long time. So more on this I teamed up with Adele to co-create this emotion-focused ketamine-assisted psychotherapy modality to build on the work that's been done so far with general ketamine-assisted psychotherapy, but to get more specific around how to do it, especially with regard to eating disorders. We conducted a formal study late last year at Cedar Psychiatry using emotion-focused ketamine-assisted psychotherapy for anorexia. And so F-KAP, as we like to call it, is based on two guiding principles: supporting the emotional health of the individual with principles that come from a very tried and tested therapy modality called emotion-focused therapy, and then also leveraging the healing power of support of others. And so on the first point, supporting the emotional health of the patient, emotion processing difficulties lie at the root of so many mental health conditions. You know, in society, at least in the past, many of us were taught to fear emotions, repress them, squash them, not express them. But that can lead to kind of a glommed up mess of undifferentiated mood states that are hard to make sense of, and that can spill out in other ways, both in physical and mental symptoms. But when we reconnect with our emotional experience, you get to take the driver's seat again of your own life, because emotions exist as signals from your inner healing intelligence to tell you what you need to navigate life in a good way. So they give us information in real time, and there's a bodily felt sense with them. Like if you uniquely, as an individual, feel fear, that shows up in your body in a certain way. And if you learn to tune into it, recognize it, then you can be guided by it. And with emotions also comes an action tendency. Fear might say protect or run, or heighten our senses and be more alert. Sadness might feel heavy and slow and in a certain place in our body, like a knot in the stomach or a lump in the throat. And then the action tendency might be to reach out for comfort, or and when we ignore these signals, they not only become less able to guide us, but we were taught, instead of showing emotions of sadness as males growing up, or say as females traditionally, instead of displaying anger, we're taught to show something else. So what might happen is when you're sad, if you get these wires crossed from childhood, from society, culture, when sad, instead of listening to that and acting on it to reach out to comfort, you might have a secondary reaction of anger and be pushing away the people who might otherwise support you. So there's this adage I like, that you've got to feel it to heal it. And the only thing worse than feeling a painful feeling is not feeling it. And it's hard to grasp at first, but when you look at the toll that disconnection from our emotion takes on anyone's life who tunes those out, it can be striking, and it makes it very clear that shedding those unshed tears, or feeling the emotion to its full expression and then moving on, can be so much more adaptive and productive than just squashing those and bottling them out until it blows like a pressure cooker in ways of stress and mental health struggles. So these, just as a review, are the steps of emotion processing. First, we tune in, we identify, become aware of our emotions, then we learn to regulate them, and then we can transform them through certain strategies in therapy, learning to harness the healing power of some of these primary emotions, like positive, adaptive, empowered anger that might help you hold boundaries where you previously didn't have the resources or the skills or confidence to do that. And so in F-KAP, emotion-focused ketamine-assisted psychotherapy, and in ketamine-assisted psychotherapy in general, we like to put a big emphasis on the role of caregivers, because caregivers represent this untapped resource for enhancing change in individuals who are struggling. So aside from the fact that your support system, your spouse, your parents, your, say, grown children know you the best, they love you the most, they're also the ones there where the rubber meets the road in your transformation. So it just makes sense to equip these individuals with the skills to support their loved one on their healing path. And this can have an extremely strong outcome when you think about the fact there's only so much we can do in an hour or two of therapy, or even a course of inpatient residential treatment, because you're always getting back to day-to-day life. And if we can keep the therapy going in day-to-day life, then the results can be so much more pronounced and lasting. So I'm going to skip over S-ketamine and talk about the MDMA study that I've been working on with MAPS and Adele France over the past year or two, and talk about why MDMA for eating disorders. So MDMA isn't a classic psychedelic. It's what's called an empathogen, unique in its ability to promote this sense of love towards self and others. It does so by oxytocin release, that love hormone that's especially prevalent when a mother has a newborn child, for example. And MDMA stimulates the release of serotonin as well, norepinephrine, dopamine, creating this picture of improved mood, more empathy, and increased or pro-social effects, moving towards the other, trusting the other. And there's also, from brain imaging studies, less activation of the alarm center in our brain, like the amygdala, that lets us go to those difficult emotions or difficult memories that we weren't able to previously. And so I'll skip over some of this so we can get to psilocybin and leave some room for questions. So psilocybin is the active ingredient in magic mushrooms. It's also in phase 2 studies for treatment-resistant depression and being studied in a number of other conditions as well, including anorexia. And so it is, this all represents a paradigm shift in the way we practice psychiatry and psychotherapy, because in a course of psilocybin-assisted psychotherapy, you come in to your clinician's office and relax in this safe and comfortable setting for a period of, say, 6 hours or so, while you have a couple therapists holding space for you. You might have headphones, eye mask, take the medicine, go on this visionary journey with insight and processing of stuck emotions and new ideas of how to tackle big challenges in life. And so that journey wears off through the day, but the embodied knowing, the experience, the mystical experience stays. So after a month of some of these studies at Hopkins, let's say 80% said this was among the 5 most personally meaningful experiences of their life. So you can really occasion a mystical experience. One of my mentors, not that I've ever met him, but someone I read about a lot is Carl Jung. And he used to say, in working with addictions as an example, if only I could bring about a mystical or spiritual experience for my clients, then we could break out of this cycle. And from the Center for Change, from my my mentors and dear friends and colleagues, Mike Barrett, Scott Richards, Nicole Hawkins, and others, I've learned that that spirituality plays a strong role in eating disorder recovery. And so data like this is striking to me about the potential we have to help people get unstuck. And just for fun, there's some history that you can look through on your own. But this is a fascinating picture to me because it shows brain pathway activity on a placebo in a psilocybin study, like a sugar pill, and then on psilocybin. And what happens is when you turn off the ego, when you tone down that default mode network, new connections can freely form. You can see the forest from the trees. You can see what these maladaptive patterns of thought and behavior are doing to our lives and what we're giving up from them. And not only see it, but feel it, know it, and take it out of that room. And with the right follow-up and therapy, can turn that into transformation. Before I wind down for questions, I wanted to make a mention of what is ayahuasca. I said it at the end because I have worked in therapeutic retreat settings with this medicine, and including with eating disorders. And ayahuasca contains the active psychedelic DMT, but it needs another ingredient to be available to the brain. It needs an MAOI, so it doesn't just get metabolized. And so that's why ayahuasca becomes basically a tea of two plants that come from the Amazon. And this is what I've boiled down the varieties of a psychedelic experience or an ayahuasca journey into a typical course, knowing that this is different for everyone. But in a retreat, therapeutic retreat setting, this is done often ceremonially, provided by the shaman, and then you sit and meditate while waiting for it to kick in, and then you have some visual effects, some altered perception, like classic psychedelics do. Every medicine has its unique signature. There might be some challenges that come along, and this is good. There's some data that comes out of the psilocybin work, and we've looked at this in ayahuasca settings as well, and I believe it holds true, is that if you have a strong mystical experience and you have an emotional breakthrough, which we measure by the emotional breakthrough inventory, if you have high scores on both of those, that's where the lasting changes come, because you have faced your fears, you have gone through that dark night of the soul, or you've had an emotional breakthrough, made it through the other side. And so the journey of ayahuasca kind of mimics that, where there's some movement of energy, might be in the form of nausea, vomiting, or just shaking, crying. But then on the other side of this is often this expansive state, that mystical experience of sense of oneness, or sense of love, of connection to others, to your true self, and then reintegrating with the real world, and with these new ideas you bring back with you, maybe some resolved conflicts or ideas of how to proceed. And so I'll read a couple quotes from ayahuasca participants. I seem to think about myself and talk about myself a lot more kindly than I previously did, and I'm a lot gentler to myself. I still experience feelings of anxiety, but I feel like they don't last as long. Whereas before I would spiral downward and get depressed and then start to restrict and start to purge and binge and all that. I feel like I can notice when my energy is changing, and then I'm more able to be with it and sort of resist and then it moves after. And so I'll just leave you with this, that I'm very hopeful of what lies ahead in terms of options for eating disorder recovery. And psychedelic-assisted psychotherapy holds promise for so many things: depression, anxiety, and I believe eating disorder treatment. It will take time. It will take many groups banding together to study these things in systematic ways, but it's a worthwhile pursuit. I've witnessed firsthand the powerful healing that can occur with these modalities. So thank you for listening and taking part in this conversation about psychedelics, and I will leave it there for questions.
Okay. Thank you, Dr. Robison. Let me get some questions up here real quick and see what we have. One question, kind of in the beginning, you were talking about a book. So someone didn't catch the name of the book.
How to Change Your Mind.
Okay. And then
That's by Michael Pollan. He's written about food, actually. He wrote, his bestsellers before were like In Defense of Food, but he's just such a brilliant writer and thinker and philosopher that, you know, his poetic journey through these substances has been a true kind of work of art.
Great, thank you. You kind of touched on this a little bit, but in the beginning, someone was asking, we're talking about the use of psychedelics, wondering if we should also include discussions of the spiritual experiences that come with it.
Yeah, I completely agree, and hopefully I did emphasize that after your question came through. I remember a couple years ago, I was working full-time at the center and took a little break to go to my kids' school for a spelling bee, and someone was sitting next to me who struck up a conversation, and it turns out it was one of the other parents, and turns out she had been in eating disorder treatment at another center as a kid, and with a serious eating disorder as a teen and young adult. And she said, you know what made all the difference for me? What was the turning point was when I tapped back into my spirituality, my connection with whatever that means to you, higher power, true self, nature, God, religion, and it was just further reinforcement of the role those kinds of things play. And I love that it's a factor in psychedelic medicine. We can talk about spirituality, mysticism, unconditional love again.
If someone has a family history of schizophrenia, do they need to be more careful or not use psychedelics for treatment?
Yeah, that's a great question, because psychedelic studies traditionally have excluded people with any personal history of psychosis and even family history, like a first-degree relative with psychosis. But that is relaxing a bit as we learn more and more about these. It still remains true that psychedelics are generally not advised when there's, you know, a history of, or especially any recent or current psychosis. But there is more data coming out that that says that, yeah, there is a risk of unearthing or exacerbating a psychotic episode, but with the right set and setting, the right support in place, the risk is small, and it can be managed with a careful treatment team, whether it's a family history or even a personal history we're dealing with. In studies, we need to be very extra clear about the inclusion and exclusion criteria. So it might still be excluded from studies, but clinically, as things evolve, I can tell you that there's still a lot to learn, and there's still some potential there.
Okay. How would you recommend for a training clinical psychologist get involved with this research as well as assess more clinical training in this area?
Yeah, it's a great question. And there's a strong and growing interest in getting involved in this kind of work. And I would say there are a number of ways of doing that. There are a lot of online and in-person training programs. If you look at some of the earliest and most well-known, well-established, that would be CIIS, California Institute of Integral Studies, for example. They have a year-long psychedelic therapist training program with, it could be doctors, therapists, nurses as part of that. But that's a big jump and a big commitment. There are also a number of training courses to start to kind of get your feet wet with this kind of thing, or at least get exposure. For example, there's a website called psychedelic.support that has a number of free courses on it. There are some ketamine specific trainings like the Ketamine Psychotherapy Associates, Phil Wolfson, one of my primary mentors in ketamine work, and I like to call like the grandfather of ketamine-assisted psychotherapy. He has a very well-established training program. Scott Shannon in Colorado has one called Prati. There's Fluence, there's Polaris. But feel free to reach out to me. If you don't have my contact info, you can ask via the Center for Change or cedarpsychiatry.com. Send a message there. I'm happy to point you towards training resources.
I'll ask one more question. There seems to be quite a few questions around kind of the, what about further addictions occurring after these treatments? You know, is there an addiction component? You know, those kinds of things as I'm starting to look through some of the questions. So that'll be our last question. If you can answer anything in regards to kind of further addictions after occurring in treatment.
Yeah, really another really good and important question, because these are controlled substances. Whether that's justified or not, that is the current state of many of these. And ketamine specifically is also a drug of abuse in some places. So is MDMA in like as a club drug, for example. But I can tell you that while there is a risk of addictive behaviors, these things aren't anywhere near the addictive medicines like opiates and even alcohol, because they do have an anti-addictive property. They have, as non-daily intense experiences, they're often very, very rarely sought out in that way of daily habitual use. But I would agree that there's a big need to make sure these are given and distributed in a safe way, and paying attention to risks of addiction as well. But there's strong data on so many psychedelics and ketamine about their potential to help get underneath the hood of substance use disorders and heal from what might be driving that, because it's not really about the addiction, it's about the pain, it's about the struggle underneath it. And if you can use these tools in a way to go to those places therapeutically that you haven't before, then, and I've seen it time and time again, then there's the chance of really breaking free from those cycles of addiction, those chains that bind us at times when we've sought things to cover up some distress, or understandably try and feel a little better in very difficult times.
Okay, well, great. Well, thank you, Dr. Robison. To everyone that's still on, please fill out the evaluation form and to watch for the follow-up email in about an hour with instructions regarding taking the post-test and receiving your certificate of attendance. Thanks again for joining us today. Thanks, Dr. Robison.
Thanks for having me.